should introduce you. Okay, we're going to get started. It is now 10:30. The panel is panel number 10, Management of the Neck in Well-Differentiated Thyroid Cancer. I'm Dr. Ralph Tufano, and the co-moderator here is Dr. Heifetz.
Good morning, everyone. How do you push that? All right. Let me introduce the speakers. And as we were thinking about how we're going to moderate this panel, we thought of a couple of lectures and then a few cases for presentations, and that's what we're going to do. So two of the panelists, the original panelists, could not make it because of the difficult times in the Middle East. So we still have Mark Cohen from the USA, who is going to talk about ultrasound and whether it can help to plan the extent of neck dissection. We have Ran Alon, who is taking Professor Talmi's place, and he's going to talk about the indications and the extent of central compartment neck dissection. We have Nomi Rabinovich, who is taking Gidi Bahar's place, and she's going to talk about prophylactic central compartment neck dissection in face of jugular adenopathy. And then John Watkinson from UK is going to talk about the indications and the extent of lateral neck dissections. So without further ado, I call Mark Cohen to give his first talk on ultrasound. Thank you.
Let's see, he's going to pull it up for you. So advanced, okay. And then laser here.
All right, thank you very much. My name is Mark Cohen. I work at Weill Cornell Medical College. It's a true honor to be invited by the program, the HNS and IFNOS, to be a part of this. It's an honor to be on such a panel with such distinguished faculty and auspicious audience members. Today I'm going to talk about general things in the next few minutes about ultrasound and whether we can use it to determine the extent of neck dissection. I have no conflicts of interest or disclosures to report. When I was thinking about this question, does ultrasound determine the extent of neck dissections, you know, there's a few options. There was, yes, it does. Maybe it does. Sometimes it does. No, I really don't think ultrasound determines the extent of neck dissection. And E, I think I'm in the wrong panel. Hopefully, we'll be somewhere between B and C, in my opinion. This is a slide when I think of neck nodes with thyroid cancer, sort of like Where's Waldo. If you look hard enough, usually you'll find him. And just sort of as a disclaimer, Dr. Mendez from Seattle used a very similar slide, and I tried to delete this slide, knowing that it wouldn't go over well after I saw his talk a few days ago, but I couldn't figure out how to delete the slide in the speaker ready room. So today, for the next 5 or so minutes, I'm going to talk about the goals of preoperative imaging with ultrasound, the problem with thyroid cancer, as we all know. Go over really the ATA guidelines as sort of a guide to answer this question as best as possible, talk about the ultrasound advantages and disadvantages, and going over situations which ultrasound helps and which perhaps it doesn't. The goals of preoperative imaging for thyroid cancer are twofold, really, to evaluate the primary tumor, the primary thyroid cancer, and to identify lymphadenopathy. Ideally, we want to look at strap muscles, invasion of the esophagus or the trachea, as well as carotid artery. And I think everyone agrees that in those advanced situations, MRI is greater than, and CT are greater than ultrasound. In addition, we want to look at lymphadenopathy. Detection of lymphadenopathy in ultrasound is found 20 to 30% of the time and alters our approach, making us, do a neck dissection. Ultrasound is operator dependent, and ultrasound is much better on the lateral nodes than the central nodes. Just to briefly show the levels that we're talking about for the remainder of the talk, we all know these nodes. The lateral compartments are 2, 3, 4, and 5, and then talk about central level 6. The fundamental problem, the issue that brings up so many panels and so many papers is the fact that lymph nodes are involved in thyroid cancer anywhere from 20 to 90%, depending on how you assess the lymph nodes, whether that be macroscopic, microscopic, or genetic testing, and they could be present with small primary tumors. The ATA guidelines in terms of workup and in terms of assessment of the thyroid in the neck is pretty straightforward, with the second strongest recommendation being to use an ultrasound to assess bilateral thyroid lobes, as well as to assess the lateral necks and central necks, and the use of CT MRI is not recommended. Why do we use ultrasound? There's a lot of reasons to use ultrasound. It's very, very good. It's very, very cheap. There's pretty good access with ultrasounds in a lot of our offices. And then just an example of some lay press publications out of an Australian newspaper called The Australian, basically demonstrating the risk of CT and ionized radiation, citing that it had a higher fatality risk than general anesthesia did at age 1, age 10, and age 20, which is pretty remarkable. What is ultrasound good for? As I said, it's good for thyroid nodules, it's good for lateral neck nodes, and the things that we look at in the lateral nodes include calcifications, loss of fatty hilum, changes in shape, vascularity, cystic appearance, and larger size of the lymph nodes. This is an example of a lateral neck node with microcalcifications that can be seen. Well, what is ultrasound not as good for? It's really not as good for central neck nodes with a wide-ranging sensitivity and specificity, but it's better than sensitivity. It's not good for mediastinal nodes. It's not good for nodes in the setting of a large lesion. And you can see here, sort of at our institution, this is just one example of many. There's a large 6-centimeter papillary thyroid tumor that obstructs the ability to see this level 4 node and the mediastinal nodes. So when it's a big tumor and you're concerned about those things, an ultrasound is not enough. Obviously, if you see a suspicious lateral node, you should FNA it, not to go over too much into other people's talks, and obviously it wouldn't be a good talk without a video that didn't work. If you identify a positive lateral node, the ATA guidelines say, on ultrasound say, you should perform a therapeutic lateral compartmental neck dissection with metastatic lateral cervical lymphadenopathy, and compartmental is something that we'll talk about what that means. This is sort of a key slide that I also tried to alter after looking at some more literature, but the likelihood of nodal disease is most likely in 3, 4, and 6 in the central neck. It's a little bit less likely in 2, especially 2B, and it's very unlikely, I'd say, in 1 and 5A, a little bit more likely in 5B. So when we talk about performing a compartmental neck dissection for thyroid cancer in the therapeutic setting, it should include levels 2A, 3, 4, and 5B. This is, again, another statement lifted from the ATA guidelines. When there is positive disease, there should be a comprehensive or selective compartmental dissection of unexplored compartments, so in the primary setting, with significant persistent or recurrent disease, with lymph nodes larger than 5 to 8 millimeters. And at this point, no one should be doing berry picking, ethanol ablation for these lymph node positive necks. Again, not to go too much into my other speakers' talks, but if there's positive lateral central neck disease, the recommendation rating of B, which is pretty strong recommendation, not the strongest, is to do a central neck in that setting. What if the ultrasound is negative? The ATA guidelines, so the experts, many of which are here today, didn't really give us too much of a way to go with it, basically saying for large primary tumors, you can perform a central neck, and for small tumors, you may sometimes not perform a central neck, leaving things pretty ambiguous. Again, what about CT or MRI? There's no guidelines for when to use CT or MRI, but certainly we should be using them if it's aggressive pathology, if there's any other symptoms that we're worried about. So in summary, ultrasound determine the extent of neck dissection. I think yes, if there's a positive lateral node, you should be doing lateral neck dissection 2, 3, 4, and 5B. If there's a large thyroid mass, it's not good enough. You need to get a CT or MRI. And if there's not a large mass and the ultrasound is negative, we're sort of back where we all began. And again, if there's a positive lateral node, as the next speaker will be talking about, I believe, perform a compartmental lateral neck dissection and a central neck dissection. If there's a positive central neck node, perform a central neck dissection. And hopefully, in the upcoming talks, we'll talk about what type of dissection and if there's a negative ultrasound assessment, and we'll talk about that. Thank you very much for your time.